Hello, my name is Wilson Gonsalves, and I'm a hematology fellow at the Mayo Clinic in Rochester, Minnesota. Multiple myeloma is a very heterogeneous and biologically diverse disease that yields a wide variation of survival outcomes amongst its patients. To date, there are various prognostic markers that help identify these high-risk patients with poor survival outcomes. Some such prognostic markers include high-risk FISH by cytogenetics, higher labeling index, higher risk by gene expression profiling, and higher ISS stage. The presence of circulating plasma cells has always been a known adverse prognostic marker in multiple myeloma. Unfortunately, most studies have utilized a slide-based immunofluorescence assay to help detect these clonal circulating plasma cells. Unfortunately, this test tends to be both laborious and complex, and hence has limited its clinical availability. With the advent of flow cytometry, it's been able to rapidly detect clonal circulating plasma cells, as well as quantify the absolute number of circulating plasma cells. Hence, the aim of the study was to see whether quantifying the absolute number of circulating plasma cells would provide prognostic significance in newly diagnosed myeloma patients. This was a retrospective study performed at the Mayo Clinic in Rochester. All newly diagnosed myeloma patients who had their peripheral blood evaluated by flow cytometry between October 2009 to November 2011 were included in the study. Those patients had met the diagnosis for plasma cell leukemia were excluded from the study. In the study, we used a 6-color flow cytometer that analyzed 150,000 events in each of the peripheral blood samples of our patients. The clonal circulating plasma cells were identified based on the high expression of CD138, CD38, the variable expression of CD45, while being negative for CD19. We had a total of 157 newly diagnosed patients that were seen during our study period. And of this group, we then went on to perform a receiver-operator characteristic analysis to help define the optimal cutoff that would predict those circulating plasma cells that would have a worse 1- and 2-year mortality. This number was found to be at 400 circulating plasma cells. When we applied this number to 157 patients, there were 120 patients who had less than 400 circulating plasma cells, and there were 37 patients who had 400 or more circulating plasma cells. We then looked at the Kaplan-Meier survival curve on these patients, and we found that the median overall survival for those patients in the group with less than 400 circulating plasma cells was not reached, in comparison to 32 months of median overall survival in the group with 400 or more circulating plasma cells. We also looked at time to next therapy, and in that group we found that the median time to next therapy for patients who had less than 400 circulating plasma cells was around 26 months, in comparison to 14 months in the group of patients who had 400 or more circulating plasma cells. We then created a multivariable model, and over here we found both older age and the presence of 400 or more circulating plasma cells to be predictive of a worse overall survival in newly diagnosed patients. We then assessed whether this cutoff of 400 circulating plasma cells would be significant in those patients with standard risk cytogenetics. Of our 157 newly diagnosed patients, there were 94 patients who had standard risk by FISH. When we applied this 400 circulating plasma cell cutoff, we ended up having 74 patients who had less than 400 circulating plasma cells and 20 patients with 400 or more circulating plasma cells. When we looked at the Kaplan-Meier curve in terms of overall survival, the medians were not reached in both groups. However, there was a statistically significant difference in outcome in favor of the group with less than 400 circulating plasma cells. Finally, we also looked at the time to next therapy between these two groups of patients with standard risk cytogenetics. And in this analysis too, we found that the group with less than 400 circulating plasma cells had a median time to next therapy of 27 months in comparison to 12 months in the group with 400 or more circulating plasma cells. And so in conclusion, flow cytometry is a readily available tool that can rapidly detect the presence of clonal circulating plasma cells. And with our study, we see that it does have prognostic significance in those newly diagnosed patients and able to predict early poor survival outcomes.